Best practices in trauma radiography. Speed provide quality images in the shortest amount of time. Exam efficiency can be increased without sacrifice of image quality. Accuracy. Proper CR part IR alignment ensures minimal distortion and maximum recorded detail. Shortest possible exposure time, reduced possibility of motion. Quality. The patient's condition is not an excuse for the provision of less than optimal images. Positioning. Position the tube and the IR, rather than the patient, to avoid exacerbating injuries during imaging procedures. Practice standard precautions. Expect exposure to blood and bodily fluids. Wear the appropriate protective apparel. Protect the IR and immobilization tools. Perform frequent hand hygiene. Clean equipment regularly. Immobilization. Maintain position of immobilization devices during imaging procedures. Remove immobilization devices only under physician's orders. Anticipation. Understand injuries that might require special projections or diagnostic procedures. Attention to detail. Monitor patient condition at all times. Trauma patients are often unstable. Know danger signs and the appropriate responses. Attention to department protocol and scope of practice. Know the scope of practice for radiographers in your region. Adhere to department protocols. Practice only within your competence and abilities. Remember that trauma patients are not allowed to eat or drink unless permitted by the physician. Professionalism. The ED is an emotionally charged environment. Adhere to the Code of Ethics for Radiologic Technologists and the Radiography practice standards. Pay careful attention to appropriate interpersonal communications and confidentiality. Patient status, changes and responses, cool, clammy skin, shock. Vasovagal reaction. Other symptoms of shock present. Excessive sweating, diaphoresis. Shock. Other symptoms of shock present. Slurred speech. Head injury, stroke, cerebrovascular accident. Drug or ethanol influence, accompanied by vomiting, especially if vomiting stops when patient is moved to different position. Agitation or confusion. Head injury. Drug or ethanol influence, accompanied by vomiting, especially if vomiting stops when patient is moved to different position. Vomiting without abdominal complaints. Hyperemesis. Head injury. Hyperglycemia. Drug or ethanol overdose. Abrupt stimulation of vomiting or abrupt cessation of vomiting when patient changes position. Hyperglycemia accompanied by fruity-smelling breath, increased drowsiness, lethargy, shock, head injury, hyperglycemia. Other symptoms of shock present or accompanied by vomiting. Hyperglycemia accompanied by fruity-smelling breath. Loss of consciousness, unresponsive to voice or touch. Shock head injury, hyperglycemia. Immediately, pale or bluish skin pallor, cyanosis, airway, compromise, hypovolemic shock. Immediately, bluish nail beds, circulatory compromise. Immediately, thirst, shock hyperglycemia, hypoglycemia. Other symptoms of shock present. Tingling or numbness, paresthesia or inability to move a limb, paralysis, spinal cord injury, peripheral nerve impairment, accompanied by any symptoms of shock or altered consciousness, seizures. Head injury, immediately, inability to feel healthcare providers' touch, spinal cord injury, peripheral nerve impairment, accompanied by any symptoms of shock or altered consciousness, extreme aversion of foot, fracture of proximal femur or hip joint. Only if X-ray request specifies frog leg, lateral projection of hip, which would exacerbate patient's injury and cause intense pain. Substitute surgical lateral position and watch for changes in abdominal size and firmness, increasing abdominal distension and firmness to palpation. Internal bleeding from pelvic fracture or organ laceration immediately. In trauma radiology, every second matters. Rapid imaging, precise positioning, and critical judgment help save lives when patients need it most.